I should really congratulate the NICE team for bringing out these guidelines at a rapid speed. And this is something which is one of the positives of this pandemic. Normally, the guidelines takes months to be published. It has to go for a lot of consultations. And our NICE team produced these guidelines within probably hours or not more than a day or two that they came out with this guidelines for managing acute kidney injury. I mean, in the UK, all hospitals do already have some form of acute kidney injury guidelines on their trust website. It's not new to us, but what these guidelines made us is just to focus a bit more on preventing. And the few things which they added is, what happens is, in these patients with acute kidney injury who also need ventilation, the slight tricky situation wherein to prevent the people getting going on ventilation, or to prevent the acute respiratory distress syndrome, which will lead them onto ventilation, you have to keep the lungs as dry as possible. So in the process, if you try to keep their lungs dry, there is a possibility that you will dehydrate the patients, which in turn can cause significant acute kidney injury. So we have to get a balance between, we want to treat the kidneys, we want to keep them euvolemic. What we say is fluid status at as much as required. We shouldn't overload them. If you overload it, then it will affect the ventilation big time. But at the same time, we don't want to keep them dehydrated to avoid the kidney injury. So that was one of the challenges which came out in this pandemic. So we dealt with that. And we also identified the patients who are at high risk of developing acute kidney injury, particularly the one with diabetes, cardiovascular disease, hypertension, on polypharmacy, particularly on different type of 3 or 4 antihypertensives, including diuretics and AS or ARBs, and people, old age, elderly patients are at a significantly higher risk of developing AKI. Patients who already has some sort of pre-existing CK, chronic kidney disease, are at higher risk of developing AKI because the reserve is less compared to normal kidney function patients. And also, people, this fever, which is a significant symptom of COVID, when you have a temperature of 39, 40 degrees, you will become much more dehydrated. You lose a lot of water. The risk of you getting dehydrated is much high in COVID patients because of very high temperature. And some patients who having temperatures of 39, 40 for days, with all the treatment, we couldn't get the temperature down, and then that will also make them dehydrated and pushes them into developing acute kidney injury. So that's one of the things. So when we identified the at-risk patients, and we tried to optimize their fluid balance to the extent to prevent acute kidney injury. And I would also like to tell you that, when it started, when the beginning of the pandemic, there was a lot of talk on ACE and ARBs, that angiotensin converting enzymes and angiotensin receptor blockers, all the drugs ending with pril, ramipril, perindopril, and sartans, increases the COVID infection and had to be stopped. I think, yes, if you look at the pathogenesis, ACE enzyme, ACE receptor will act as a carrier for COVID virus. But I don't think there is much evidence for that. So what we took a very strategic decision is, we didn't stop the medications who were already on ACE or ARBs, because it's a good thing to do. Because if you stop the ACE, it might worsen the progression of kidney disease, or sometimes it is for hypertension. And if you don't control the hypertension, then that will be an adverse factor. And for heart failure, it can make the heart failure symptoms worse. So I think it was counterproductive stopping these medications. So we kept them on these medications, but then they have to follow the sick day rules, which is, we normally, when we start patients on these ACE or ARBs or diuretics, we always tell them, when you become unwell, when you don't feel well, or if you got vomiting or if you got temperature, you need to avoid taking these tablets temporarily. And if you're too unwell, obviously report to your doctor, but even before you consult the doctor, you're safe to withhold the tablets for a day or two until you feel better. So based on that advice, I think we carried on with the people on ACE and ARBs. We had a lot of phone calls from patients as well regarding this, what we need to do. And this is the advice we gave. But we didn't start somebody on ACE or ARBs for hypertension because we had other options. So we avoided that. But if it is absolutely needed for example, if somebody has very high proteinuria, I think we didn't shy away from starting these medications because of the benefits it has. So I want to tell you about that. And the guidelines also did eventually, apart from managing the acute kidney injury, it also touched upon the renal replacement therapy in COVID patients.